between iris and the posterior comial surface is called anterior synechia of the iris. If this adhesion occurs at the angle of the atrium, it is called goniosynechia. Inflammation due to ciliary body spasm and pupil sphincter continuous contraction can cause miotic pupil. Part of posterior synechia cannot be drawn apart. Multiple pupil appearances appear after dilated pupils, such as quincunx, piriform, or irregular shape. If posterior synechia of the iris is 360 degree, it is called seclusion of pupil. If the fibrous membrane covers the entire pupil area, it is called occlusion of pupil. In anterior uveitis, pigment can be deposited on the anterior surface of the lens. And ring pigment can be left on the anterior surface of the lens when the fresh posterior synechia pulled open. Next sign is iris nodules. Iris nodules is characteristic of granulomatous iritis. Aggregates of epithelioid cells and lymphocytes in the iris stroma. Koppe's nodules is on the pupillary border. Busacca's nodules is near the iris root. Look at the pictures. The first picture is Koppe nodules, on the pupillary border. The second picture is Busacca nodules, near the iris root. The third picture is Koppe nodules at the iris margin and Busacca nodules on the iris surface. Above is the signs of anterior uveitis. Let's review. Hyperemia, ciliary or mixed. Keratic precipitates, KP. Anterior chamber flare. Anterior chamber cell. Posterior or anterior synechiae of the iris. Iris nodules. Seclusion or occlusion of the pupil. Some fibrinous pigmented deposits in the pupillary area of the lens. Next is complications of anterior uveitis. The first is complicated cataract. As a complication of the inflammatory process, or due to the prolonged use of corticosteroid. The second is secondary glaucoma. The mechanism is blockage of the trabecula meshwork with inflammatory cells. The associated pupillary block caused by a seclused pupil. The consequential formation of peripheral anterior synechiae. The third is hypotony and phthisis bulbi. Inflammation, repeated or chronic, can lead to ciliary body from or atrophy, decreased aqueous humor secretion, cause the hypotony, serious can cause eyeball atrophy. Complicated cataract. As a complication of the inflammatory process, or due to the prolonged use of corticosteroid. Recurrent or chronic cataract inflammation causes aqueous humor changes and affects lens metabolism, resulting in cataract. In addition, in anterior uveitis, due to long-term use of glucocorticoid eye drops, can also cause posterior capsular opacity. Secondary glaucoma. When secondary glaucoma anterior uveitis, intraocular pressure can be increased or secondary glaucoma can be caused by the following factors. Inflammatory cells, cellulose exudation and tissue debris blocking trabecular meshwork. 2. The anterior adhesion of iris or inflammation of trabecular meshwork obstructed aqueous outflow. 3. Seclusion or occlusion of the pupil occlude aqueous fluid from posterior chamber to anterior chamber. Diagnosis and differential diagnosis of acute anterior uveitis. Diagnosis can be made according to the clinical manifestations. Since many systemic diseases can cause uveitis, it is important to determine the etiology and concomitant diseases for guiding treatment and predicting prognosis. Therefore, patients with acute anterior uveitis should be consulted in detail history, especially to ask whether there is lumbosacral pain, joint swelling, urethritis, digestive tract alien, reticulum system abnormality, and other systemic lesions, to determine whether accompanied by ankylosing spondylitis, reactive arthritis, inflammatory bowel disease, psoriatic arthritis, tuberculosis, syphilis. Laboratory tests include routine blood tests, erythrocyte sedimentation rate, ESR, HLA-B27 antigen typing, etc. For those suspected to be caused by pathogen infection, corresponding etiological tests should be carried out. Differential diagnosis of acute anterior uveitis. Acute anterior uveitis is mainly differentiated from the following diseases: acute conjunctivitis, acute angle closure glaucoma, high tension with sudden marked loss of vision, mutilated pupil and edematous cornea, subconjunctival hemorrhage. The differential diagnosis with acute angle closure glaucoma is the key content. Acute angle closure glaucoma is characterized by sudden marked loss of vision, intraocular hypertension, corneal clouding, mutilated pupil and edematous cornea. Look at the pictures. The first picture is acute anterior uveitis, presents with ciliary hyperemia. The second picture is subconjunctival hemorrhage. The third picture is acute mucopurulent bacterial conjunctivitis, presents with conjunctival hyperemia. The last picture is acute angle closure glaucoma, presents with comial clouding and mixed hyperemia. This chart is the differential diagnosis of the three diseases. 1. Pain. Acute conjunctivitis, foreign body or gritty sensation. No pain. Acute anterior uveitis, pain radiating along first division, ophthalmic, of fifth nerve. Acute congestive glaucoma, severe neuralgic pain radiating along all three divisions of fifth nerve associated with nausea and vomiting. 2. Vision. Conjunctivitis, not affected, may be slightly blurred. Anterior uveitis, moderate diminution. Congestive glaucoma, gross diminution sometimes reduced to just pleural. 3. Discharge. Conjunctivitis as mucopurulent. Acute anterior uveitis as watery, serous. Congestive glaucoma as watery, serous. 4. Congestion. Conjunctivitis as conjunctival congestion. Anterior uveitis as ciliary and conjunctival congestion. Congestive glaucoma as ciliary and conjunctival congestion. 5. Cornea. Conjunctivitis as clear sensation normal. Anterior uveitis as mild edema sensation, normal KP on back of cornea. Congestive glaucoma as cloudy or steamy insensitive. Anterior chamber. Conjunctivitis as normal. Anterior uveitis as normal or deep. Congestive glaucoma as shallow. 7. Pupil. Conjunctivitis as normal size reaction normal. Anterior uveitis as small, irregular sluggish reaction. Congestive glaucoma as large, vertically oval fixed. 8. Intraocular pressure. Conjunctivitis as normal. Anterior uveitis as low, normal or raised. Congestive glaucoma as markedly raised eye stony hard. 9. Ciliary tenderness. Conjunctivitis as absent. Anterior uveitis as present. Congestive glaucoma as absent. Treatment of acute anterior uveitis. The treatment principles is immediate dilation of pupil to prevent and open fresh posterior iris adhesion, and rapid anti-inflammatory to prevent ocular tissue destruction and complications. Treatment against inflammation, steroids and non-steroidal anti-inflammatory drugs. Dilation of pupil and prevention of complications. Aim is relieve pain and discomfort, prevent sight loss, and eliminate causes of disease where possible. Cycloplegic is the treatment of acute anterior uveitis. Essential drugs. Once the onset should be immediately administered. Its purpose is relieve pain by relaxing the ciliary muscle and sphincter spasm. Prevent sticking of iris to the lens. The most commonly used cycloplegic is cyclopentalate, scopolamine homatropine, or atropine BID to QID. Postmate-open action time is about 18 to 36 hours, can make the pupil in a state of continuous movement, so it can effectively prevent the occurrence of posterior synechia. The dilation of pupil and paralysis of ciliary muscle of postmate-open is inferior to atropine. However, atropine has a long duration of ciliary paralysis and pupil dilation, 10 to 14 days, so that the pupil is in a relatively fixed state of dilate. Also easy to occur posterior synechia. Therefore, for severe acute anterior uveitis, 1% minus 2% atropine should be given 1 to 2 times a day. Treatment for a few days. When the inflammation is alleviated, use 2% postmate-open, 1 to 2 times a day. When fresh posterior synechia is not easy to dilate, subconjunctival injection of dilated pupil mixture can be given. Includes atropine, cocaine, epinephrine equal amount of mixture. For mild inflammation and recovery period can be given topicamide. Steroids. Action mainly as being anti-inflammatory and immunosuppressant, although wide-ranging effects. Make up the major part of uveitis treatment. Used in different forms. Eye drops. Periocular injections. Injections locally around the eye. Systemically via the bloodstream, either by oral, tablets, or intravenous infusion, drip. The mainstay of therapy as a topical steroid includes prednisolone acetate, dexamethasone acetate, up to Q2H initially, then taper very slowly over weeks to months depending on etiology and response. It is imperative to monitor the patient's IOP since steroids can cause an elevation in pressure. In steroid responders, consider changing to a preparation with less tendency to raise the IOP. For patients with corneal epithelial keratopathy that are not suitable for steroid eye drop treatment, subconjunctival injection of dexamethasone can be given. For patients with reactive optic disc edema or macular cystic edema, dexamethasone can be injected under the tenon capsule. For patients with bilateral acute anterior uveitis showed reactive macular edema and optic edema, prednisone can be given orally, at the initial dose of 20 to 30 milligrams, taken orally in the morning, and reduced after 1 week of use. The general treatment time is 2 to 4 weeks. Treatment for the cause. Treatment will be different depending on what caused the uveitis. Infection antibiotic, antivirus medicine. Trauma wound repair. Autoantigen, eliminate. Ancillary medicine. Non-steroid anti-inflammatory drugs, NSAIDs, mainly exert their anti-inflammatory effects by blocking the metabolites of arachidonic acid such as prostaglandin and leukotriene. It has been shown that post-operative or post-traumatic inflammation is caused by arachidonic acid metabolites and can therefore be treated with non-retained anti-inflammatory topical eye drop 3 to 6 times daily. Oral treatment is generally not required. Immunosuppressant. Glucocorticoid combined with other immunosuppressant can be considered for patients with systemic lesions. Treatment for the complications. Secondary glaucoma. Intraocular pressure-lowering drugs can be given, when necessary combined with oral or intravenous. In patients with pupil block, Laser iridotomy or peripheral iridectomy should be performed as soon as possible with aggressive anti-inflammatory therapy. Extensive goniosynechia can be corresponding to anti-glaucoma surgery. The picture is laser iridotomy for secondary glaucoma. Use laser to cut a hole in the peripheral iris. The posterior aqueous humor may enter the anterior chamber. The pupil block has been released. Phacoemulsification for cataract. Phacoemulsification extraction and intraocular lens implantation should be performed under the condition that inflammation is well controlled. Local or systemic glucocorticoids should be used before and after surgery. Other immunosuppressive therapies should be combined when necessary to prevent the recurrence of postoperative uveitis.